So what happened over the space of a couple of years, we had 50 patients running over 37 groups a week, everything from chair-based exercises, ukulele groups, singing choirs. We had an annual music festival in the GP car park. So much of what people suffer is as much about community well-being, social well-being, physical well-being, and security well-being. I'm really talking about Gallup's 5 elements of well-being there. There's so much extra that feeds into health, but the solution to that are those things. And in the absence of those things, I'm not surprised why that GP appointment becomes so important to that person that's struggling from loneliness. And so it's a sticking plaster, but it won't cure it. We've got to get to the stuff underneath that to begin to address that.
It's fascinating, isn't it? I mean, at the end of the day, it links back to what we said at the start of the conversation. The GP's list is the community health centre is at the heart of the community. Hi and welcome to Health Beats, one of the world's leading international healthcare podcasts brought to you in association with Abu Dhabi Global Healthcare Week. I'm Steve Gardner, Managing Director of Healthcare World, and I will be your host as ever for another interesting and exciting debate. And if you haven't already subscribed to Health Beats, why ever not? You'll find us on Apple Podcasts, on Spotify, wherever you get your podcasts, and we're starting to develop quite a library of really good content. So lots and lots of stuff to listen to if you're interested in understanding more about what's going on in global healthcare. And actually, if you want to understand what's going on in global healthcare, you could do a lot worse than tapping up my guest today, Methven Forbes, as we know him. Managing Director of Fuller and Forbes, a primary care provider group in the UK, now resident of South Africa, global primary care expert who's joined me on stage pretty much all over the world. Mev, how are you doing? How's South Africa today?
Hi, Steve. Thank you very much. Great to see you again, and thank you for the invitation to join you today. So I'm doing really great. As you know, my name is Methven Forbes. I'm in Cape Town at the moment. And the weather, I have to say, is very different to what it was when I left the UK 2 or 3 months ago, going from minus figures to, I think, a cool 31 degrees today.
Well, if it's any consolation, Mev, I'm in North London and I've got the heat on. So there you go. But anyway, our listeners don't want to hear about our relative weather issues. I think what's really interesting, what they really want to get into is understanding what's going on in global primary care. And I think in order to kind of get deep into that topic, we first have to do a bit of definition, don't we? I mean, this might sound like a ridiculous question, but from your perspective, what is the definition of primary care? What is primary care all about?
Yeah, that's probably the biggest question before we do anything else. And I think the problem with it, and I think I've said this to you before, to quote someone else actually, it's a bit like an accordion word. You'll get whatever sounds out of it depending on how much hot air you blow into it. So I think that's one of the big problems with trying to define primary care. I think at its very core, it's rooted in that community service where you have local residents that have an emerging health problem, and who do they go to? And what we want to do is say the hospital is not your first port of call unless it's a serious injury or an emergency. Your local medical practitioner is your first port of call. And so that's really looking at around the need for urgent care and an ongoing care. And I think the other thing with primary care is there is a gatekeeping element to it. In the NHS at least, we certainly view primary care as the gatekeeping role to the remainder of the NHS services. So rather than patients going straight to diagnostics or specialisms, what they do is they go through the primary care physician or medical practitioner who is best able to ascertain what secondary care services might be required or what tertiary services might be required. As I kind of gave the game away at the beginning, the problem with that definition is that's really not how it's evolved. It's become a dumping ground, I guess if you were to look at it slightly negatively, a dumping ground for everything else. And I think we need to kind of unpick that a bit more.
I think there's an interesting point here, isn't it? Because if you think about the evolution of primary care, why did primary care come into being in the first place? Because ultimately, you can't deal with every individual in every case in every situation in a hospital. So ultimately, is the starting point for primary care the idea that the health system needs a first point of contact? It needs a triage point. Is that where primary care begins for you?
I think so. I mean, again, if you look at cities in the UK, like Leeds, for example, 800,000 people, and you have maybe five hospitals, physically, it's just impossible for everyone to squeeze through five front doors for all of their healthcare needs. And it's probably not the best use of their time or a hospital's time. So I think primary care being both a service that can diagnose and treat, but also as the filter of what goes into secondary care, I think it's got to be the starting point for sure. Yeah.
And you talk about this idea that it's being a dumping ground, because the first rule of primary care is the idea that it's a triage, it's a
Yeah.
way of filtering and routing people into the right place in the health system. And the right place in the health system could be go home with an aspirin. It could be, go to acute care, go
Yeah.
directly to acute care, do not pass go. It could be you require mental health services, social services, whatever it may be. How and why has that started to snowball, and how and why have other services and other requirements
Yeah.
been dumped into the primary care bucket?
Yeah, look, I mean, I use the term dumping ground, and depending on what day you catch me, that's either a bit of a pessimistic view or a bit unfair, because I think the truth about primary care and one of its strengths is that it is a community-based service, and certainly from the UK perspective, it's a medical centre that has a registered list, has a capitated list that generally is geographically aligned with that medical centre. So essentially, you have a local community and you have the doctors and nurses that look after the primary care of those individuals. And so I think what happens, or what's happened over time, is people have begun to realize actually there's a lot of knowledge being built up there, especially with the advent of electronic medical records. What we have is this incredible data source of information of people's lives, of people's interactions, of people's comorbidities, for example. And so when governments and policymakers start contending with lots of other issues, and you think about the social determinants of health, then, in one sense, it is understandable why people would think, well, actually, if you want to kind of change behavior, surely the people best placed to do that are those that are working in a medical or health environment at a local level. And I remember someone once saying to me, I think it was Martin Fisher from King's Fund, said, in the UK, you tend to have three sorts of registered lists that people identify with. You have medical centres, you have schools, and then you have local churches, Church of England, where they're very much geographically located. And I guess the point of saying that is that if you imagine school as one of these education sources, their primary role obviously is to educate. But you can imagine policymakers and people genuinely thinking, okay, but they know their parents, they know the children, they know the community. Well, why don't we get them involved in lots of other things since they have a lot of knowledge and a lot of insight into those issues? And again, there is sense in that because I do know primary schools and secondary schools that do some work around, mental health and nutrition and those sorts of things. The question there, though, is at what point does it begin to move away from its primary mission rather and lose sight of what that primary mission is at the expense of all of these other things? And I think to take that and bring that back into primary care, I think we can ask the same question as, what is the core mission, the vision and mission of primary care? What are those things that are added value? But what are those things that are at risk of derailing primary care and pulling us into an area where institutionally, it's just not structured to deliver at a scale, and that could be down to economies of scale or the skill sets that you have within primary care, or funding.
And I guess there's a thing there, isn't there, that in a universal health coverage system where everybody has access to healthcare, whether it's free or paid for, whether it's the UK, whatever country you may think of it, if you've got a universal health coverage system, then you have a situation where every citizen has access, and this is their point of access to the health and care system. So therefore, logically, that communication wheel can turn the other way. So when it comes to outreach from the health system to the citizen, primary care becomes the point of contact.
Yeah, look, I mean, there is a logic in that. The question I have is how. How can we make that possible? Because what I definitely don't have across our 18 medical centres, 350 staff members, is a lot of doctors and nurses with a lot of free time on their hands. It's funded as such that it takes all of their time to deliver medical services, and that is the bottom line. That's the bottom truth. So if we are to put responsibilities on primary care to do more than that, then one, there has to be time available. But then you have the other issue around clinical governance or governance is, medical centres are GP led from a clinical governance point of view. So if we're extending the remit of what primary care is, what about the training and education that GPs need to kind of go beyond their core role, their own training, to be clinically responsible for a wider set of areas?
And I suppose there's a thing there as well. I mean, it's almost a can you just problem. And so you look at, for example, I mean, it's probably wise to call these things out in terms of the issues that general practice and primary care faces. It's becoming the station for public health messaging. It's becoming the area for vaccination, particularly in a post-COVID world. We've got the preventative agenda, the collection of data, the intention of creating precision medicine or population and health outcome based activities. And I guess you end up with can you just make sure that you're collecting the data from everybody that comes in your door? Can you just make sure that you're delivering anti-obesity messaging, smoking cessation messaging? Can you just actually, while you're at it, make sure that everybody's had their vaccination? Is that how this works? Is that how the snowball gathers as it comes down the hill?
It does, and I think when I think about data collection, we've got really good data collection systems in primary care for sure, and I think the NHS as a whole it's extremely data rich and it has all these pools of information from many different areas, and primary care is very likely to be one of those big drivers of that. I guess practically speaking, nurses and GPs might have 10 to 15 minutes per patient. And during that time, the jacket comes off, you greet them, you sit them down, you make them feel at ease, you get them to open up about their health problems, you ask further questions, you then write it up in the medical records, you then talk about the treatment plan, the options, make sure they understand it, and then the jacket goes on and you say goodbye. It's a lot to do already within 10, 15 minutes. If what we really want is appointments to become much wider, then we have to start thinking very differently about how primary care is structured.
We need more time for one thing, don't you?
More time, yeah, for sure, and definitely more economies of scale. I'm thinking of a place where I used to be a practice manager, a managing partner, Punsey. I don't know, 30, 40,000 patients, and maybe half a dozen, 6, 7 primary care centres, medical centres. Is that really a good use of estates and resources? And I think actually, yes, I do definitely agree with the sentiment that if you had fewer medical centres working at scale on a geography, then I think primary care could be structured to do more. What I don't think scale means is just lots of medical centres all joined up to make a big number. It's got to be meaningful scale. And I think meaningful scale when it comes to population health management and prevention and public health, it's got to be geographic scale, because that's where you're employing people and that's where you're integrating with the community.
I think there's a really important point to raise here, though, that is the level of access, the level of demand for primary care in a universal health coverage system like the UK, where it's free at the point of delivery, as opposed to an insurance-led system like the US or the Middle East. The demands are very different, and therefore the time and the opportunity is very different, isn't it? How do different primary care systems around the world compare?
Yeah, that's a huge question. And look, I mean, I've spent some time in Australia, and they have a system where patients pay. They might get a rebate back from the government, but they're still at a fee basis. But they still have general practitioners. Patients still register with a medical centre, albeit it doesn't stop them from getting sort of, minor illness, urgent care from elsewhere if it's cheaper. So, I think that system works. I think the UK system sort of works, but I think it's coming under strain in terms of what universal free at the point of need or free at the point of want means. And then you look at some of the American insurance models where patients pay or through their insurers pay. Then of course there's all these controls around what they're paying for and how much care patients can access. And then that's a whole conversation around value-based care versus quality-based care. Well, as I would perceive it, it's one of the things that I kind of talk about at the moment. Um, I the motive is very different, isn't it? If you have an insurance-based system, then primary care is going to look different because the motive from both the patient and the insurer is totally different. Insurers don't wake up in the morning and think we want to spend all our money on making the world a better place. They want to deliver their core contract and make a profit at the end of it, understandably. From patients, if they're having to make a contribution, they only want the care that they think they need, which might not necessarily be what they actually need, and which might be yet again different to the insurers. And that is the flip opposite to the UK, where politicians will understandably say, well, every patient has a right to have care when they need it. But how that gets translated is care when they want it, which is a totally different thing from needs. So you've got two opposites there, each with their both strengths, because obviously on the pay-for model, insurance model, there is an element of demand control, which is the issue that the NHS suffers from. But then you have the issue of, is it the right treatment? Are we preventing care for the wrong reasons by virtue of the system? And then you have on the NHS side, where the doors are wide open, but then the system is creaking and struggling because people will just use it for things that are much more wider than just medical. And a part of that is because the medical view isn't the whole view of a person's health, and that's where the issue comes from. Is it interacts with so many other areas, and from a patient point of view, where do you go with that? If it's a free service, it'll be your GP, and so yeah.
It's a really interesting point. I mean, it's something that you brought up with me the last time we were together on stage in Dubai, I think, where you talked about the idea that the UK system is not free at the point of need, it's free at the point of want.
Yeah.
And that's a very, very different thing. And I do remember that we were debating with primary care leaders in the UAE who were absolutely shocked at the idea that you would have to wait several days in the UK in some cases to get a doctor's appointment, when what they were struggling with was actually getting people to value and use and come into their primary care clinic. It does make for a very different set of priorities, doesn't it?
Yeah. It does, and you know what? That I'm sure will change. If they were to introduce free at the point of need, it will take a generation maybe for culture to change, for people's behaviour to change. The thing is how do you what are the lessons from the NHS that can be taken to make sure that we don't repeat the mistakes of the NHS, but we take all the goodness from it and replicate that elsewhere.
Well, I mean, one of the stories that I always found fascinating, particularly from a Middle East point of view, is that even fairly recently, and I'm talking to the last 2 or 3 years, and even now amongst older members of the population, GPs are not considered to be proper doctors. The old joke: what do you do if you get a headache in the Middle East? You go and see a brain surgeon, and yet there is, in both systems, is there not, a move towards understanding how you can take the strain away from the doctor and actually get allied health professionals, nurses, even pharmacists to help take the strain. So, in terms of that point around how you divide the workload, where do you sit with this? Do we need to have a kind of multidisciplinary approach to the delivery of primary?
I think, 100%. I think that's got to be the way forward. And you made a really good point. Certainly in Saudi Arabia and other parts of the Middle East, they don't necessarily have the general practitioner role as we understand it. What they view as a general practitioner is someone that hasn't specialized and therefore maybe board certified. And so it's almost like a junior doctor position. I can't remember the term of it, but it's something like that.
The terminology that I heard, it was family medicine consultant is the phrase that's being bandied around.
Yeah. So And I think that's quite interesting. So then in Saudi Arabia, you have your general physicians, and then you and working in primary care that are uncertified, and then you have this emerging, family medicine consultant role. I think there's a hybrid that I could see forming. I think that needs to happen actually. So in the UK, it used to be that it was GPs and GPs only that provided care, and certainly when I was a child, I was registered with a GP, and that GP provided all my care. If I was sick at 2 in the morning on a Saturday, then that GP would come and visit. The GP provided 24 hours, 7 day a week care. Things have moved on a lot, and certainly the emerging of technology, of different primary care specialisms, of medicines, it has changed the way primary care is being delivered in hospital care. And so what we now have in the UK, which I think is a very good thing, is you have a lot of different specialisms that work under the term of primary care. So, for example, in our group of medical centres, we will have general practitioners, we will have advanced nurse practitioners that have been trained at postgraduate level to consult, diagnose, treat, prescribe, refer. We have advanced clinical practitioners that can do broadly similar things, but from the perspective of their professional background, which might be pharmacy or physiotherapy. We also have clinical pharmacists now in primary care, physiotherapists, and a number of other roles. And so there is sense in that, because not everything needs the most expensive person to treat. A headache does not need a brain surgeon unless the MRI has shown there's something going on there that needs a brain surgeon. Other than the fact that maybe you ate too much or drunk too much yesterday, and that's why you've got a headache today. So I think I think the way that I see primary care evolving is that you'll end up in the UK, for example, is with a primary care consultant, a GP who really doesn't provide all of the care, but provides the higher end care, the complex stuff, but also provides the clinical governance and the clinical supervision for those working underneath them, which I think is a very safe way to do it. So, if someone comes to the surgery and they're feeling a bit ill, they've got the cold or cough or whatever, sure, they might be seen by a nurse practitioner or a minor illness nurse, but there'll be triggers around that, and it'll escalate up appropriately, and to the point where a general practitioner will get involved if it turns out to be something much more serious. And the NHS has got a lot of experience doing that and doing that safely. I was talking to someone actually that I met in Dubai, saying that one of the issues in certain elements of the insurance market within America is part of the reason why there might be resistance from primary care physicians working in primary care to expand the multidisciplinary working, is because of the medical legal risk that comes back on them, that if they get it wrong, then they're going to be sued, and then that's going to affect their reputation, their employment, their funding, all of these sorts of things. Whereas in the UK, medical legal indemnity is covered by the Crown, so it gives the ability for medics to take on multidisciplinary teams and to assure themselves and the organisation of the governance and the pathways. And so, so I can see something that brings the hybrid of the primary care consultant or family medicine consultant in Saudi Arabia, but overseeing a team of primary care physicians on the ground. And of course, primary care physicians or primary care teams doesn't just have to be clinicians. You can then start looking at dietitians and nutritionists and well-being coaches. But then we go back to the argument I said at the beginning about the need for economies of scale to do that.
Yeah, it's a really interesting one, and I think the other point around where primary care sits globally at the moment is the global shift of hospital to home, delivery of healthcare in a home environment, utilisation of technology. The burden of that change, how much does that sit in the primary care bucket?
One of the things I would like to see, and I know it definitely is emerging, especially around, smartwatches and smartphones and technology that can actually that can take diagnostic readings. I think, if we have a move towards integrating that data into primary care would be a very good thing, because yes, we do a lot of chronic disease management in primary care, a lot of long-term conditions management. And some of that is based on blood pressure readings, ECGs and all these other sorts of indicators. And so I think, getting to a place where we can capture that data, automatically and have it integrated within the medical records is a very good thing. And likewise, patients having access to the medical records remotely rather than having to come into the general practice is a very good thing as well, so they can see how that's affecting their health. Um, I, I think there's lots of other technologies that could come into play, but I could see that being much more in towards like care homes, intermediate care homes, those places where you might have care workers or social workers or nurses looking after patients on a residency basis, but not necessarily needing a GP at that time. I think there's a lot of really exciting stuff that's coming out of there.
There's a couple of interesting examples actually of what you've just touched on there. I mean, you've got on the one hand in Abu Dhabi at the moment they're trying to develop systems that will allow clinicians to access the well, it's not Malafi, it's now been renamed as Sahatna. The integrated data platform that they're creating there. So being able to see a patient's medical record as you see them, and also integrating work from the Emirati genome programs that gives somebody an overview of a patient when they get there. Is that the kind of data that you're talking about that you'd like to see practitioners having access to at the point of care?
Yeah, so I think there's a triangulation there, isn't there? That there's the data that can go into healthcare systems from the patients. So there's a lot of really exciting technology around that. But then there's a lot of different types of providers that are involved in the healthcare of a patient. Interestingly, when I visited Kaiser Permanente a few years ago, they shared this story where they had lots of different specialisms, and every specialism with their own clinical system, and none of it interoperable. And so they tried to then design their own one and almost went bankrupt in the process. And then what they ended up doing was getting one that off the shelf that could be customized to their needs. And they've not looked back because everyone is working from the same medical records. That's kind of like the story of the UK in some ways, where we have hundreds and hundreds of clinical systems, medical record systems across all tiers. Talks of in the history of a centralized clinical system called Lorenzo, for example, that not progressing. And so now the big move is around interoperability. I think that is still the challenge within the NHS. So in primary care, there's half a dozen medical systems that we can use. And sure, there is some data transfer when a patient moves from one region to another region on a permanent basis, but it's not necessarily the exact centralized singular medical records. And certainly when it then comes to the hospital and you make a referral to the hospital, we still by and largely put a lot of clinical information in the referral letter so that the consultant knows what on earth is going on with the patient care. Now, local cities have created shared care records, which is where each of these clinical systems pulls out and puts it in another one that kind of acts as a sort of a hub, but it's still obviously a limited amount of data. I definitely think the next huge evolution in the NHS is for us to move towards, a singular clinical system, or certainly a singular data set that the interface of clinicians then use, which might look different depending on what the specialty is, and that's just a natural byproduct of that.
I think it's an area in which the UK is very much behind the Middle East in that regard. I mean, we just talked about Sahatna in Abu Dhabi, similar system that's being designed in Dubai, and of course there's going to be the same single record system that's being developed across Saudi Arabia. It's almost kind of slightly bizarre to think that the UK is so far behind in that regard. I think the other element of digital primary care that we need to think about is that of remote consultation. I mean, during COVID, it became more and more, I don't want to say socially acceptable, but more understood and demanded that we would see our GP or our primary care physician virtually rather than physically. How far down that line do you think we've got globally now? Do you think we're in a position where we are starting to deliver our primary care in the living room, virtually, over the phone, using apps, or are we still some way away from that yet?
I think it's a bit of both, really. I mean, certainly in the UK, you're right, COVID changed a lot. We were all moving over to telephone systems and then e-consultation systems. I mean, we have our own bespoke one, and we must carry out over 100,000 e-consultations a year. But what we do is we give patients a choice. And so, if they want a face-to-face appointment, they can have one. If they want a telephone one, they can have one. And if you want to do an e-consultation, filling out the consultation online, they can do that as well. There's elements of that where there's still a choice on the provider side as well. So there's still a lot of medical centres that really shy away from e-consultations and telephone calls. And sometimes that's around training. Sometimes that's around the risk, especially if you have individuals that just feel very uncomfortable trying to treat or diagnose and come up with a treatment plan over the telephone. And even more so when it's an e-consultation. So it's a list of questions and answers you get. There might be an element of generation in that, where, younger people coming up are much more averse to, the primary method of communication is, sending messages and text messages or WhatsApp or whatever. So I don't know. I think that's an area of growth. I think it's an area that's emerging. We can see that in the UK. There's a policy that came out in April that will require every GP in the UK to provide an e-consultation service by October. Now, it doesn't specify the extent of that. So, theoretically, it could be as simple as being able to order repeat medication or request a GP sick note to providing a fully comprehensive, consultation service, which is what we do. I think that's an area of growth, but I think it's an area of nervousness as well, because you are talking about a very big cultural change in how doctors and nurses consult and diagnose and prescribe. And so everyone that's currently in practice who's employed in those roles didn't come through medical school or nursing school with modules specifically focusing on how to get the most out of e-consultations or those sorts of technology consultations. And so they carry that legacy. They then think about medical legal risks, and then they think about all this emerging technology that they're supposed to harness. I think we've got to move with it, because I think it's going to be much better for us, much better for the patient, much more efficient for the health service. But I think we've also got to take clinicians with us, and we've got to demonstrate why it's safe and how it's going to protect them from medical legal risk as well as providing the training and education to do it so that they get to the point where they're comfortable.
I think this point around educating clinicians and educating clinical staff around the use of technology is a really important one. It's come up a couple of times on this very podcast with various guests. How do you go about, in your opinion, bringing your clinical staff on the journey with you in terms of socialising technology, getting them behind and backing the use of that technology, and indeed training them to use it? How would you go about that?
So again, I think this is where economies of scale is really important, because if you're a small provider, the chances are you've only got a handful of people. And so it's all or nothing. Either they're all on board or you're not doing it at all. And I think that's a very difficult place to start from. In my experience, when you're wanting to bring about change, you really need one of two things, or ideally both. You want an economies of scale as a center so that you can not necessarily have everyone signing up to it, but you can have some people that are willing to give it a go, the innovators, the people that are interested in that sort of stuff, to kind of demonstrate to the wider team that it's possible. And you can do that if you have a certain economies of scale. The other way that I've been able to do it is that if as a medical provider, you're growing. So in the UK, if our capitated list is growing by 1,000 patients every year, that's 1,000 new patients, 1,000 patients worth of new money. Well, you can spend that in different ways. And so if we force our clinicians to do it, the one thing that will happen is resentment. The doors will close, and if they're truly forced to do it, it won't be good for patients or for clinicians. I think what we've got to do is, and certainly how we do it, is we find a coalition of the willing to say we're going to have this as an add-on service, not as a replacement service, and we're going to run and see how it works. And we give everyone the chance to see it and to see the benefits beginning to work their way through. So, for example, we recruited actually a bespoke team to do our e-consultation service. So these are regulated professionals. We didn't simply pluck them out. And then we demonstrated the benefits. And some of the benefits was the fact that it reduced face-to-face appointments. The conversion was only 20%. Other benefits was around compliancy and the fact that we don't have quite as many patients trying to get through the telephone at ATM. And suddenly what happens, if it works, that service that became an add-on becomes an essential service. And then you get buy-in because you've demonstrated it and you've got the credibility to do it. I think that's got to be the way, especially when you especially when you're dealing with regulated professionals whose license is on the line. If we as non-regulated professionals but managers get this wrong, we've got to protect them.
It's a really interesting point that you raise as well, because it's, on the one hand, you've got the use of technology, whether it be from an appointment making point of view, from a digital triage point of view, from a remote consultation point of view, which, again, the incentives are slightly different, aren't they? I mean, in a free at point of delivery system, those things are all there to reduce the burden on the clinician and the demand on the system. Flipping that around to those insurance-led models where demand the opposite, you've got the opposite problem. You want to increase demand, you want to get people coming
Yeah,
into primary care. How can those systems use that technology to increase confidence, to bring more people through the
yeah.
door? Is it a question of just making it easier for them?
Cool. That's a really, really interesting question because obviously, from a Kaiser Permanente point of view, they work almost as an integrated system. So they're all
Yeah,
part of the
yeah.
same family. So it's much easier to make those sorts of changes, and their culture is there and is supportive of it. So they all feel they're on the same team. I think when you have maybe an insurance system where there's lots of different providers working for different insurers as well, it's much more complicated. So certainly talking the people that I've talked to about this, the starting place has got to be looking at the medical legal issues around this and the confidence that we put in around protecting them from being sued by trying new innovations. You know, it's one thing to innovate and try a new, I don't know, blood pressure check, blood pressure machine or MRI scan, which has already gone through serious amounts of governance. But when you're talking about tools that aren't so much like that, but actually replace elements of what they physically do in terms of conversations and taking tests and readings and those sorts of things. The medical legal governance has got to be there to protect them, and it's got to be supportive of them. And I think I'm sure talking to a friend of mine in the States, that was one of the issues around Obamacare. Wasn't that it was necessarily wrong. It's just that the governance and the medical legal side wasn't supportive of it. So I think if we want to encourage insurers to utilize those sorts of technologies, then the first place must be to look at the regulatory regime and look at the medical legal aspects of this to say, okay, is this going to raise the likelihood that patients are going to sue the doctor because, well, I didn't get to see a doctor, I saw a nurse practitioner instead, or I had to fill out a form. We've got to protect them from that and move that conversation on. And then I think we'll start getting better buy-in because, everyone wants tools that will make their job easier. No one's saying they don't want that, but they also want to be safe and to be secure because, like the rest of us, doctors and nurses have mortgages to pay for, families to feed, those sorts of things. So yeah, that for me would be the starting point.
And there's a couple of interesting points, I think, around the medico-legal side of use of technology. I mean, on the one hand, there was a study that was done a few years ago now that a friend of mine was involved in, actually, where they looked at AI-based symptom checkers. And they
Yeah,
looked at the efficacy of the technology in terms of, using survey results, people's medical
yeah,
records, basic data entry from the patient perspective through various different systems to actually working out what the diagnosis looked like and how accurate the
yeah,
diagnosis was. Now, this was 5 or 6 years ago, but the interesting thing about those symptom checkers is that they've not become widely used as yet, because at that point in time, the result 75% of the time was go see a doctor. And the
yeah,
reason why the result was go see a doctor was because any risk at all that the AI or the technology had got it wrong meant
yeah,
better. We need a human being to get involved
yeah.
here. How are we? Is that ever going to change? Are we ever going to get to the point where the robots can diagnose the
Yeah.
disease?
I mean, when you think about the types of diseases that are out there or illnesses, and you think about some common symptoms like coughing, sneezing, headaches, pain, there's an awful lot of conditions that meet that criteria. Everything from a common cold to the onset of Ebola. But so there's a risk there, isn't there? And you can go into NHS checkers and
So,
run
Nev,
this
is
too.
this the idea that whenever you Google your symptoms, you're always dying?
Yeah,
Is
that's
that the
exactly.
concept? Yeah.
Yeah, that's right. Because the body only has so many different ways to express something's up, something's not quite right. So it does take judgment. And so the way that we are going to be addressing this is, as I said earlier, we have our own e-consultation system. We're in the process of developing a bespoke AI side of it. And so what will happen is the patients will complete the e-consultation. And then the AI component, after being rigorously trained with hundreds of thousands of consultations, will produce a suggested history plan, suggested diagnosis, suggested treatment plan, suggested next steps, suggested medication if relevant, linked to the drug formulary that we use in the UK, and then suggested referrals, if appropriate, linked to the referral pathways in the UK. Now, the key point there is that's a lot of work to do in the first place. The bit that's important for us is that we still want a clinician, a doctor or nurse practitioner to look at that, to read it, and to provide the governance that, okay, this is correct, this is right, because there's a lot of time involved in typing and reading and stuff like that. So we're talking about efficiencies of data collection and the presentation of that information and the possible outcomes. And learning will get that probably 99.99% accurate, but we still want a doctor or nurse to validate it. But that is still much, much more efficient than the potentially the face-to-face element of it.
I suppose one of the issues there is the fact that any kind of diagnostic tool that's based around computing or AI or whatever is absolute. It looks at the information that it's been fed and comes up with a conclusion based on the information it's been fed. But quite often the information is coming from human beings, and how many human beings really admit how many glasses of wine they drink in a week or how many cigarettes they smoke. There is that kind of human variance that requires, and it's also from the clinician's point of view, a diagnosis is an opinion. It's an opinion based on experience, sure, but it's an opinion. Can a machine ever really have an opinion? There's a whole broader debate we could get into that could take us hours.
Look, a GP will make an opinion, but it's an opinion based on the training and education and the repetition of what they see. And that's essentially what we're saying with our AI model, for example. The difference being is we still want a real human being to step in and say yes and no. Now, to pick up on your point, what you were saying about about the AI models, about patients telling the truth, for example. Now, I know people who have got asthma and who smoke, and then about a week before their annual asthma review, they stop smoking. They go to their asthma review and they tell the nurse, "No, I still haven't smoked ever since I quit 4 years ago," and they're the star pupil. And then as soon as they get a clean bill of health, although it doesn't make sense because they need stronger medication, away they go and they start smoking again. It's no different. Patients will say what they say to clinicians based on how they feel at the time. And there's also times when patients leave and say, "Oh, I forgot to tell this to the doctor or this to the doctor." What I will say about e-consultations is, generally speaking, because patients can do it at home, sat on their laptop without pressure, we tend to find we get a lot more detailed information. And so the quality of information we get is a lot higher. Not necessarily 100% of the time, but certainly more times than not, it's a lot more qualitative.
It's interesting when you talk about home consultations, and I just want to run this one past you because I think it's fascinating. I was talking to colleagues at NEOM the other day, who hopefully we'll be seeing on the podcast in the reasonably near future. I interviewed Mahmoud Al-Yamani, the head of healthcare at NEOM, and we talked extensively about their approach to primary care and the idea that high status, high value real estate at NEOM, you'll literally have a cupboard somewhere in your apartment where you open it up and there's a video screen, a big red button, and a bunch of medical equipment. You press the big red button, your doctor appears on the screen and says, "Oh, okay, pick up the stethoscope, put it on your down a bit, and it gives you kind of live information, and that they are looking at as very much a replacement, and there will not be a requirement for primary care facilities if you're able to do that level of remote consultation." I just wonder if you could comment on that for us. Do you think that would work? Are we a little bit technologically away from that yet?
I think that will work. I think we've got to warm the system up slowly with that one, because certainly in the UK, getting people to get used to telephone consultations, videos, and e-consults has been a massive cultural change, and it still feeds its way through international media. Um, but I mean, look, I'm waiting for the delivery of a brand new VR AR headset. It's a new launch from a new company. But it's 4K or is it 8K? 4K per eye. It's immersive. You know, you can have conversations. You know, so it's almost like Apple Provision, but much more advanced. I can easily see a day in the not too distant future when you put those on, and the quality of, I can see you like I'm seeing now, but in a much higher resolution, and looking at you at the same height, and then it opens up a whole possibility of worlds around what that means for consultations. For example, when I was in Saudi Arabia, was it last September, October for the health conference there? They had this equipment that was, a bit like a health pod, but you stand in front of it and then it scans you up and down, and then it'll tell you what your temperature is, what your vital stats are, all of those sorts of things. That's technology that was probably developed years ago that's now fed its way through. But with the emergence of AI and all these other technological revolutions that are happening around us, there is going to come a time in the not too distant future, I think, things like that is going to be much more commonplace. When we've all got 4K cameras in our houses, we're all wearing, technology and headsets, and like you say, we can get a lot of diagnosis through that. What it won't replace is the types of care where you need the therapeutic relationship, a real person. Like, I'm down in Cape Town. I love my family. I love my friends up in Leeds and the wider UK. As much as I love speaking to them all the time, like this, for example, I still want to see them once every so often for a hug, for a meal. And so there are certain types of things in primary care where that face-to-face contact is crucially important, whether it's risk or care of the elderly or cancer diagnosis, for example.
Well, again, we started this conversation about the increasing burden on primary care, and actually, technology doesn't, and you hark back to the days when, certainly in the UK, you had the family doctor who, as you said, would come out at 2 o'clock in the morning if you were
Yeah,
feeling ill. Yeah, I remember a GP friend of mine telling me a great story. Uh, up in your part of the world, actually, up Leeds way, where there was a little old lady who would come into the surgery every week with some kind of different complaint. Oh, my feet are hurting, my legs hurting,
yeah,
I've got a headache, whatever else. And actually, the condition she was really suffering from was loneliness.
yeah,
And the GP just gave her that human contact of just sitting her
yeah.
down, talking to her for 10 minutes. Is there a danger with all of this use of technology that we lose that person to person, human to human contact?
The obvious answer is yes. But I think the less obvious answer is that that's systemic of something else. That the GP can provide companionship, but that's not the solution for that individual. So, for example, at Robin Lane, where I used to be a partner, we bought the building next door. We set up our own charity, and we invited patients to come and volunteer to run groups. And so what happened over the space of a couple of years, we had 50 patients running over 37 groups a week, everything from chair-based exercises, ukulele groups, singing choirs. We had an annual music festival in the GP car park. So much of what people suffer is as much about community well-being, social well-being, physical well-being, and security well-being. I'm really talking about Gallup's 5 elements of well-being there. There's so much extra that feeds into health, but the solution to that are those things. And in the absence of those things, I'm not surprised why that GP appointment becomes so important to that person that's struggling from loneliness. And so it's a sticking plaster, but it won't cure it. We've got to get to the stuff underneath that to begin to address that.
It's fascinating, isn't it? At the end of the day, it links back to what we said at the start of the conversation. The GP's list is the community health centre is at the heart of the community.
Yeah.
And it is that community meeting point. It is
Yeah.
somewhere that we all have in common. which I think is a really fascinating element to this. We've only got a few minutes left. I want to touch on another topic that I know is very close to your heart, and again, this speaks to that element of specialisation, that element of socialising the GP or the primary care physician
Yeah,
as being of value, and that's the point around education, training, and regulation
yeah.
in primary care. Is it right, and I'm deliberately asking this as an incendiary question, is it right that a general practice doctor, a generalist whose job it is to be the triage point, the first point of contact with the health system, that doctor is regulated in the same way and using the same organisations as a brain surgeon? It's
Mm.
still, in the UK, it's the Royal College of Physicians, it's the General Medical Council. Should we be thinking about this differently in terms of primary care as opposed to acute care? Not just doctors, but across nurses, allied health professions, even the whole
Yeah,
facilities themselves.
yeah. So, I think that's a phenomenal question, and certainly our quality care commission regulator in the UK. I've most CQC inspectors are fantastic and work really hard. But what they have to work with is very challenging, in terms of the rules and the processes they've got to follow through. An example of that is there was a report released last October, essentially condemning the current regulatory regime for primary care, stating that it's absolutely not fit for purpose and is not working. And of course, that's beginning to feed its way through now. And we've certainly experienced that very recently through a CQC inspection where it was a broken assessment. So, but I think the change that needs to be made, and I've thought very carefully about this because I struggle to understand how on earth and why on earth CQC could possibly think they could regulate a doctor or a nurse any better than their own professional regulatory body. And because what we're really asking doctors and nurses, for example, is to ensure and to give us assurance that they're following the best evidence, that they're not outliers, or if they are outliers, there's a reason for it, that there's education and training in place. So it's an assurance around the care and the treatment that they are providing. I don't think CQC has a role in that to play. I think that role has got to be with, for example, the General Medical Council, because who better to understand what the role of a doctor is in primary care and how they should perform and what's expected in them. But of course, that then leaves the primary care as a system or medical centres as a facility. And so, certainly having visited places like Saudi Arabia, I do like the idea of licensing. I have to say that licensing of premises to provide medical services, because what we're actually saying is you have this regulated doctor and you have this regulated nurse, and they're really great people, work hard, deliver good outcomes. We want to make sure that when we put them into a setting, that setting itself is fit for purpose and will support them to do the best and to deliver the best care that they can deliver. That's where I think primary care licensing would come in. So you look at and that premises would keep those individuals safe as well. So a medical centre, does it have a health, is its health and safety fine? Is its fire safety fine? Is its rooms compliant? Are the managers supportive of them? Do they give enough feedback and enough information to help those clinicians grow and to learn and to benchmark each other? There's a range of things like that. So I would separate it out, and I would have the regulation of the premises, which is the licensing for that site to be fit and compliant to provide primary care medical services, for example. And then you have regulation around the clinicians themselves through some sort of, every 5 year review of a bit like GP validation, but taking it much more meaningfully than what they do now. As it stands, and certainly looking at CQC, the domains, it's superficial, it looks good, but when you get into it, there's an awful lot that doesn't work. For example, one of the items we're regulated on is have staff been involved in the development of our vision and mission? Well, no. Why? Well, because the vision of the NHS is created further up the line. That's why it's publicly funded. And the mission is directed by the contract that we've been given by commissioners to provide healthcare. If what they're really talking about is some being involved in an operational plan, that's fine, but that's not what we're being regulated about. And there's a range of things like that where there's a massive failing. And that's where primary care ends. From a hospital end, I don't see how that one regime can cover all of these bases when it gets something like primary care very wrong, and to the point where it itself has published a report condemning itself just in the last 6 months.
It's a really interesting one, isn't it? The big question is, how do you measure quality in primary care?
Yeah,
And what you're assuming there is the idea that you need to examine the quality of the facility, you need to
yeah,
and ensure the quality of the clinical staff,
yeah,
and that they are up to date, that they are regulated, and they're working to top of their licenses. I guess when you extend it beyond that, you also need to think about regulating the processes, the
yeah,
clinical processes, the clinical governance that follows behind that. And on the basis of this conversation, do you also need to look at it from the point of view of governing the quality of data and the quality
yeah,
of the digital solutions that sit around that? How would you
yeah.
if we put you in charge for a day, how would you pull all of that together
Yeah,
into a set of regulatory standards? How easy to do would that be?
yeah. Look, I think, look, I mean, I'm being quite tough on CQC, but I'm also aware that they've been given a tough hand to deal with, and so they're trying to execute it in the best way possible. But because it's not working, we have to be able to talk about it and challenge it. And I think, I do think the situation in the UK is very complicated because we've allowed it to grow into this sort of complicated thing. I would go very simply. I would go right the way back. And you're right. What is it we're regulating? We're wanting to regulate the quality of what our clinicians do, and we're wanting to regulate that the premises keeps patients safe and they keep clinicians safe and that it's fit for purpose. Those are the three things. And so that's where I would start. And so there's a range of things that you can list, and I can write them off in my head what that would look like in terms of premises regulation. It's not overly rocket science, but at least then when you're regulating that, you can get the right people in who have got the competency to regulate that. On the clinical side, I would definitely view it very differently to what's happening now. As I've kind of said a few times, I'm much more into quality-based healthcare because I think it's much more intuitive from a clinician's point of view. It's rather than looking at activity or outcomes that where we don't always have control over, primary care, you can give an asthmatic all the advice you want about smoking, but if they still choose to smoke and end up in hospital, I'm financially penalised. How does that work? Because that money is core income for me that will now result in the loss of a nurse. So it doesn't make sense. What makes much more sense when we're regulating clinicians is to think about what does quality look like. And so, well, how do you define quality? We might ask ourselves. Well, what does the evidence base say? And this, by the way, applies to how we bring in technology and AI. And this is why I think quality focus is so important. So what does the evidence base look like around this area or this disease or this pathway? What is the approved drug formulary against all of those different things? And then you come up with a system whereby we hold clinicians to account. And when I say hold them to account, actually giving them that information to say, this is what we're expecting of you, but we're expecting this because this is what the evidence says. We expect you to follow evidence-based practices, evidence-based prescribing. We expect you to follow the criteria for pathways into services in hospitals. So then not everyone's perfect. So then what do you do about outliers? Or how do you detect outliers, for example? Well, that's where you need good medical records that are data rich, because then in our system, certainly you can run reports and you can look at all of that. You can look at clinical behavior, how many blood tests they've done for what, look at the referral behavior, and you can then look at that, for example, on a per 1,000 basis. You can stratify that through age and sex, etc. And you can begin to benchmark clinicians and get a sense of where people are. And so someone might be higher, but they might be higher unaided because they're new. And so they've not done anything wrong. That tells me what we now need to do is provide supervision and support. And there's an opportunity for clinical audit cycles. It's an education opportunity. Someone else might be higher. For example, I did have a clinician that was very high on referrals to urology, but when you dig down, he was the only male in the partnership, and most of his patients that he referred were over the age of 65 and were also male. So actually, he needs to be an outlier, because if he was the same as everything else, that's a problem. So there's got to be a view of evidence base, of your formulae, of your pathways into the local services. You then have to have a monitoring system that allows us to see that behaviour and to allow clinicians to supervise, to discuss, to do case reviews, and then you can hold it to account. If you then still have clinicians that are off doing their own thing, then you're not really talking about that. You're talking about performance management and something else. But that, again, is a quality matter.
So there's two things really that come out of that for me. I mean, the first thing is that what you're talking about there is eminently sensible, but put it against the background of where we started the conversation, the ever-evolving requirements of primary care, the ever-evolving, new things that are being brought in. It strikes me that that evidence-based and the way that you do all of this would need to be under absolute constant review in order for it to remain fit for purpose over a period of time. The other thing that I find quite interesting is that, and unfortunately we're going to do a whole other podcast on this one, is the point about value-based healthcare and outcome-based payment models. Because, if you've got a situation where your outcomes, I mean, the example that you gave about asthmatics and smoking being a beautiful one, the issue there is if you're paid based on outcomes, I think maybe we need to come together again at some point in the near future. Maybe bring a couple of friends with us for this one, for a debate about outcome-based payment models in primary care. Because I think that there's probably a big rabbit hole we could fall into there, isn't there?
There is, because I mean, as you probably figured, I'm not a big fan of value-based healthcare, because I think it's aiming for the wrong stuff. And not only that, I've seen far too many examples of where, for example, you have GP surgeries that will have very clear ways to attract certain types of patients and exclude others. And so their outcomes are going to be very different. And of course, they get rewarded for it because their unplanned admissions are far less than someone else's. I think I understand why it's come about. But it does feel to me that it's the kind of thing you would come up with if you actually really don't truly know what's happening on the ground, as in what you don't understand what the evidence is and what the behaviour should be from a clinician. So how else do you control costs? Well, on average, don't do more than 2 of this or 3 of this or 6 of this. I think, and to be fair, when it came out, we didn't have the quality of the data that we now do. So setting is everything. It came about at the right time, in its place. Things have moved on now. We're data rich. We can move to a quality driven system, and then quality costs what quality costs.
Ma'am, unfortunately, that's all we've got time for today. Thank you so much for joining us on Healthbeats. I mean, a fascinating debate all around. Primary care is the first point of contact in the healthcare. The incentives that sit around it are sometimes perverse. It's being overloaded, it's not being regulated in the right way, but at the end of the day, one thing that we do know from our travels around the world is that there is a huge impetus on the development and the creation of better primary care. So I think that's something that we can all get on. Mev, thanks for your time.
Thank you.
Everyone who's watching, make sure that you subscribe to Healthbeats on Spotify and Apple Podcasts, wherever you get your podcasts. We'll see you on the next Healthbeats. Thanks again.